Hello, everyone, and welcome to Recovery Machine, episode 15. I'm your host, Corey, and I'm here with co-host Nathan and a special guest. Welcome, Nathan, first of all.
Well, hello there, Corey. I'm going to refer to you as Corey Williams, maybe, or I'm going to have to figure this out because our guest's name is Corey Ranger, spelled the same way.
Hello, Corey.
Hi. How's everyone doing today?
We're good, thanks. How are you?
Yeah, I'm doing great.
Thanks for doing this. I know you've got quite the schedule going there, so we will try to be as efficient as possible with your time. So I guess if you could maybe start by giving us a little rundown of your career, where you started as a nurse, and how you got into harm reduction, how you got into that field.
Absolutely. So yeah, my name's Corey. I'm a registered nurse. I have been working in harm reduction for almost 10 years now, and started off by doing my final preceptorship in nursing school at a place called Streetworks in Edmonton's downtown core, embedded within the Boyle Street Co-op. And getting to learn from incredible people like Marlis Taylor and Erica Schoen. And then when my nursing practicum completed, I was fortunate enough to move right into a role with them. And I completed a temporary bloodborne pathogens project that focused on working with people who were homeless and either HIV or Hep C co-infected or co-infected with both. And then when I completed that project, I moved to Calgary, where I worked on the harm reduction team for Alberta Health Services and at the STI clinic. Later on, moving back to Southern Alberta, where I did a whole number of fun things, including starting up an HIV program in Brooks, the Take Home Naloxone project in Medicine Hat, and then was working on supervised consumption services in Medicine Hat before the Alberta government changed and they permanently froze funding to our site. Wow. During that time, I also was an instructor at Medicine Hat College for a nursing program. And when the big changes happened in Alberta, my partner and I decided that it was time to move back to Vancouver Island, where I was born and raised. And I came in right before the pandemic started and was working for the BC government on a provincial training tool for people with lived and living experience of drug use and mental health. And when the pandemic took hold, I took a leave of absence from that job and started working in the homeless encampments in Victoria. And everything has been off the rails since. It's been a very much roller coaster ride of working within the context of COVID-19 and overdose, and most recently have been working to implement safe supply programming for people who are at risk of overdose by the toxic drug supply.
Yeah, that's a great opener.
Suppose you asked why I got into this, which is a little bit of an interesting story in the fact that I actually came into nursing school with some pretty terrible preconceived notions about substance use and had grown up in a considerably conservative household. And it wasn't until I did my clinical placement with community health and was working with people who experience homelessness and people who use drugs and getting to learn from them and hear their stories that I realized everything that I had thought I knew was wrong. And the reason why I went to Streetworks was to continue to try and challenge those biases and have never looked back.
Completely understandable and relatable. I find myself in the same position where I've been looking at this, the field of addiction, and especially as it pertains to healthcare professionals. And I find myself thinking that I've got it figured out one day, only to have to reverse my thought pattern and go another way when new evidence comes forward. And it seems that at least with our government, that is something that is not an easy thing to get them to do, and it is not something they do quickly. Not that they do very many things quickly, but this one seems to be particularly tedious. We see when we were researching, we saw that your name pops up under a lot of different titles. So I wonder how many of these things are, kind of remnants of things that you were doing, or if you're still actively involved. We saw that your name comes up as president of the Harm Reduction Nurses Association of Canada. Is that a title that is still active?
I am currently the president of the Harm Reduction Nurses Association. Yes.
Okay. And what can you tell our listeners what that entails and what that organization is about?
Yeah, the Harm Reduction Nurses Association is an organization for nurses who are working in the field of harm reduction, but also nurses and associate members. So, people who work in healthcare, people with lived and living experience, people who teach, basically to develop stronger advocacy for drug policy revision, to partner ourselves and to align ourselves with the people who are working in this field, who are working with lived and living experience, and to make sure as nurses that we are listening and honoring and affirming and uplifting the voices of people who use drugs. As we work in this sector, it should be about them, not about us. We work on education, and we complete monthly webinars and roundtables where nurses come in and share their experience working in a wide array of different projects and fields, whether it's practicing harm reduction in inpatient psychiatry or community-based managed alcohol programs. We run roundtables as well, where we have more informal discussions amongst nurses about certain ideas or concepts, and try to develop position statements so that we can be as strong as advocates as we can, and always coming from the nurse perspective, which is really important. We oftentimes are people who are on the front lines of this toxic drug supply crisis, like field medics trying to figure out what's going to work, and we make lots of observations, and oftentimes don't get to be at the tables to share those observations or to help inform policy development or change.
Right. So go ahead.
Sorry, go ahead. No, go ahead, Nathan.
So you're facilitating. You're basically trying to keep the facilitation of current frontline knowledge heading in the right direction to people who are responsible for drug policy. Is that what I'm understanding there?
Absolutely. While also building capacity amongst nurses and offering opportunities for mentorship for nurses who are new in this field, offering solidarity, because it often, there's quite a bit of vicarious trauma that's experienced, and how do we support each other? Also do work with, nurses who have potentially landed themselves in trouble with substance use at work, and trying to advocate for changes from the work safe perspective so that there isn't so much stigma behind all of that. And yeah, it's a great organization, and I encourage everyone to check out our webpage and consider getting a membership.
Yeah, I'll definitely look into that. That sounds like exactly the type of communication and framework that we need.
Corey, given that it's a national association, what is it like going province to province? I mean, the landscape is so different from within each province of Canada, within each region of our province. So how do you navigate that?
Absolutely. So our board is composed of, there's Western, Central, Eastern representatives. And so there's intentional representation of major regions, and the access to harm reduction, the differences in policies across provinces is quite stark. And oftentimes, what happens in BC and what people see in BC doesn't even seem achievable if you're someone who's working in Alberta, or if you're working under the Ford government in Ontario. And it's a constant reminder that a lot of the gains that we make in harm reduction don't actually feel permanent all the time, because despite there being strong evidence for policy development to all move in one direction, this is one of the fields where it is chronically subjected to ideology and rhetoric as a form of evidence, and a government's priorities can completely shift on the basis of an election, and so can the funding models that come from there. So part of the work with HRNA is to hopefully build solidarity between those nurses and to share practice and to do knowledge exchange so that we can attempt to move the needle forward and to support some of our provinces, support some of the nurses in provinces who are experiencing that inequity at this point in time.
Yeah. Wow.
And it must take an incredible amount of patience. I can't imagine how many times you run into a wall and you just, to me, it's staggering. The approaches, some of the, the tough love, the old school punitive, we need more police on the ground type of thing. It doesn't seem to matter how much evidence is presented. These old ways of doing things seem to be embedded very much, like you say, in politics. And that in itself is unfortunate, but it is a reality. It's the
same reason why we don't have decrim right now.
Yeah,
governments know the harms of the war on drugs. They know that prohibition has driven the drug supply to the most dangerous heights that it's ever been. They're not stupid. They see that, but there's no political courage or appetite to actually change that because it's ultimately about voters, and oftentimes voters don't care about drug policy. That's not what's most important to them. And it only becomes important when it touches you personally. We see that even with politicians who suddenly change their narrative, and it's because they've had someone close to them impacted by the toxic drug supply. And we need to stop waiting for everyone to have relatable experiences before we just give a shit about everybody who's dying right now.
Yeah, absolutely. Yeah. Well said. I think that's the same conclusion we came to, Corey Williams, is that it was basically, like you said, the government, they're well aware, they're informed, they have the same numbers as we do, and but it's political. It would be a political disaster to try and tie that into any sort of a run.
Yeah, and I guess naively, I think years ago I thought that just in time that would change, that would get better, and maybe it was just a misunderstanding of the politics of it. But it doesn't. It hasn't worked in a linear fashion at all. In fact, in many ways, we're further back.
Absolutely. Like the Ontario government changed supervised consumption services to consumption and treatment services just because they needed to add treatment into the language as a means to satisfy their voting base. The Alberta government is now requiring people to provide healthcare numbers in order to access supervised consumption services, which anybody who knows anything about supervised consumption services knows that the anonymity is one of the biggest reasons people find it accessible to go there. And so they're actively pushing people out of these sites. And there's no evidence for it. There's no rational reason to support that kind of policy change other than a honest disdain for people who use drugs.
Yeah, unfortunate, but true. I wonder what you're seeing as far as, you probably have a very good idea of what's going on presently with safe supply, probably across the country. We noticed, today we were discussing just before the podcast, I see that they've got a program that just started today for a take-home fentanyl prescription, where a patient can go in and I guess they talk with a nurse, they discuss dose and form, and then they're allowed to purchase fentanyl and take that home for consumption. What I'm seeing and what I'm hearing is often very different than what is actually being done. And all I know is that it's right now it's just one person in BC who is starting this program. So we're talking about how much pressure is on this poor guy not to screw it up. But I was wondering what you thought about that particular program and what you're seeing because they've been in BC, they've been kind of toting this. Yeah, we're doing safe supply, but in reality, it's not getting anywhere. It's not really accessible.
Yeah, I'm happy to hop up on my soapbox right now and just say, if you are not in British Columbia and you're looking over here and saying, "Oh my God, BC has a safe supply," in reality, we do not have a safe supply of drugs. We do not have a regulated and accessible and effective option to supplant the illegal drug supply to have a meaningful impact on overdose death rates. We have the makings of it. We have some early starting points for it. And many of the ways in which it's being delivered currently is in a way that's super inaccessible for people. And so, truth be told, there's around 90,000 British Columbians at risk of overdose, maybe more, who are accessing the illegal drug supply. And the last estimates from the province was around 3,600 people who had accessed some form of a safe supply, which equates to exactly 4% of the people who may need it. The concentration of that uptake has been almost exclusively in Victoria and Vancouver's downtown east side. And then the ways in which the drugs have been provided have not been effective in actually curbing someone's reliance on the illegal drug supply and ultimately reducing risk. When BC first rolled out safe supply or risk mitigation guidance prescribing, they did so very wrongfully under the guise of COVID-19 prevention. And so they came out with safe supply because they believed a lot of people who use drugs were going to get sick by COVID. They were going to need to isolate. And while isolating, they would not be able to access their regular drug supply. And so they would provide a prescription, a short-term prescription of hydromorphone tablets that would help avoid experiences of withdrawal and dope sickness. And so in that entire framing, first, they connected safe supply to COVID-19. And what that means is that for someone who's going to prescribe a safe supply, they don't know if this is a permanent intervention. They don't know if when COVID ends, they'll still be allowed to prescribe safe supply. And so it gave it the air of impermanence, which if you're a doctor or a person who's able to offer this intervention, like a nurse practitioner, there's ethics behind starting someone on an intervention that you don't know if you can actually maintain. And what are you going to do if you have to cut them off? So much harm has been done by deprescribing across the country and in all of North America. People die from deprescribing and forced tapering. And so that immediately threw some trepidation in prescribers' hands. But then they framed it as a withdrawal management tool. And in essence, what that meant is they were saying safe supply is treatment. And safe supply is not treatment. Safe supply is meant to be about agency of choice and about people having the right to know what they're putting in their bodies and the ability to access that, full stop. But when they framed it as a withdrawal management tool, they basically said people are only going to use this if they're dope sick. And people use drugs for so many reasons. Mm-hmm. And so it was delivered the wrong way. The type of drug that was offered, just tablet hydromorphone at low dose ranges, was not what people were asking for. People have been asking for diacetylmorphine or prescription heroin for years. They've been asking for compassion clubs, buyers clubs. People have been asking for actual safe regulated supply of fentanyl versus the fentanyl that they're taking, which is contaminated with all sorts of benzodiazepines. We tested a sample just a couple weeks ago that contained carfentanil, fentanyl, etizolam, fluoroprazolam, and lidocaine for some reason. And the combination of that, of a short-acting benzo, a long-acting benzo, carfentanil, fentanyl, and then lidocaine, which has its own potential health hazards embedded within it, just goes to show that people are being poisoned right now by the drug supply that they're being forced to access. And then coming out of the gate and saying, here's 12 tablets of hydromorphone, it just pales in comparison to what people actually need.
Right.
Now, what Christy Sutherland and the Portland Hotel Society and Vancouver Coastal Health are doing with the model that was discussed today, that was revealed today, is very courageous that they're trying, because the truth about safe supply is that there is no one singular model or option that's going to solve this horrific crisis of preventable death. The answer is options. People are going to need to know that they can go to a place and they can potentially buy it. They're going to maybe sometimes need to go see a doctor. Maybe they need to go to a dispensary, like we've done with cannabis through legalization and regulation of cannabis. People need people need options when they have no money to just go to a consumption site, and instead of using their contaminated supply, being offered an alternative right there with no strings attached. If we invest in options, then we might actually start to see a continuum develop where wherever you are in your substance use journey, you've got somewhere you can go that will prevent you from dying and give you the opportunity to work on whatever else is important in your life. So I think what's happening in Vancouver today is really exciting because it's another model. It's another option that needs to be explored and invested. It is still medicalized, and we need all full investments going towards demedicalized options. We need to acknowledge that lots of people don't need to or want to see a doctor, and putting that barrier in place actually prevents a large amount of accessibility.
Yeah, and nor do I think we should be putting the pressure on docs to be responsible or be liable in these cases, because I mean, our doctors are already, you know, the amount of stuff they've got on their plate. I can see how, even if they had the wherewithal, I mean, look at how they're treating them normally just with prescribing for pain. I mean, they can't. To put somebody on a narcotic right now, they've got to do an extra, half an hour's worth of paperwork, and then that patient is the liability is all piled on them, and I understand why they are shying away from it. That's something we were talking about earlier. Was we were wondering if this was to be successful, and we were optimistic, and we did move to a more progressive model. Would it follow the same trajectory as what happened with cannabis, where it was kind of the medical side of it was kind of the first access point, and then once that had been addressed, it was finally with enough evidence or whatever. I mean, we've always had the evidence, but whatever it takes, I guess it's the politics needed to be proper, or the timing need to be right. But eventually it moved on to where it's along the lines of alcohol, where it's a recreational consumption.
Yeah, a lot of drug policy changes go through a very awkward, inaccessible, medicalized transition phase. I was working in a physician's clinic when cannabis was prescribed by doctors. It didn't make any sense for doctors to be prescribing cannabis, especially the doctors who weren't going in it to try and make a capitalistic venture off of it. The doctors who were just working in family physician offices, they didn't want to prescribe it. They also didn't want to be a barrier to it. Right. It just didn't make sense, right? And then cannabis clinics opened, and that was kind of weird. I don't know if they still run those, maybe, but now we see access, and we see what it looks like through an accessible, regulated model. Where people, just a month ago, there was a recall on cannabis because there was a moldy batch, and they were able to track and regulate that supply and prevent people from getting sick from consuming it. So in essence, by the regulation, they've made it safer for everyone to consume it. And those dispensaries still have regulations and controls in place. There's still age limits. There's still things that are in there to safeguard unintentional harms. Is it fully something that you can completely eliminate? You can't with alcohol either. There are still concerns. There are still accidents that happen. There's still health consequences of chronic alcohol consumption. But if we go back to the days when it was prohibited and people were going blind by toxic wood grain alcohol supply, we've made a lot of steps towards improvement. Yeah. If you look at nicotine replacement therapy, that used to be prescribed by a doctor. If you wanted to get on the patch or the inhaler, which is a safe supply of nicotine, you needed a doctor's prescription, and that didn't make any sense either. I remember having to do pulmonary function tests with people and make them breathe in tubes to determine their lung capacity before they could go on a patch. And now, through a public health model, you can go to a pharmacy in BC, fill out some paperwork, and you fall into category A, B, or C, and that gives you a certain amount of nicotine covered by the province. We should do that too with opioids. Yeah,
I guess maybe that's the tough part for people to understand is the way we've been kind of bombarded or molded by our culture is that we've got these illegal drugs that are somehow different or more dangerous, or they've villainized it to the point where it's almost like another category. But if you're looking at it in reality, there is no difference between these things. You've got coffee, you've got nicotine, there's a wide array of things that people use to either for recreational purposes or to get through their day. This is a reality of being a human being. So moving towards a model where those things are accessible, especially in this bizarre time where we've got almost 7 people dying a day because of the only thing they can get their hands on is toxic fentanyl.
Yeah, I mean, like, people don't want to support a safe supply because the stigma around fentanyl is that it's killing people, but fentanyl is killing people because of the criminalization of certain drug use. And the iron law of prohibition states the harder the enforcement, the harder the drug. And so we're, with our own shitty policies, making these drugs less safe for people and then using that as an argument not to provide a safer version of it.
It's
a
insane.
Self-fulfilling prophecy where everyone just continues to lose in the end.
Fentanyl was basically a byproduct of more policing. Like
fentanyl was primarily a byproduct of the war on oxys.
Yes.
Which, again, about physicians, just a few years back, they were being blamed for substance use disorder and overdose because of overprescribing of oxycodone. And a short time later, we're telling them we need them to prescribe liberally these types of medications as a means to reduce instance of overdose. And they're probably thinking in the back of their heads, when is this going to come back on me? And when am I going to be the villain again?
Yeah.
And it's a really short-sighted, lacking context way of looking at things, but it is definitely one of the biggest drivers for prescriber hesitancy.
Totally understandable again. And we were discussing this before the podcast, how difficult it must be for doctors. They look today, they wake up and they look, and now here's this guy going and he's buying fentanyl in powdered form from a pharmacy with a prescription. And he's like, okay, the doctors are saying we're back to this again. Like, what the hell is going on here?
So, Corey, has there been any transparency in British Columbia around folks that were put on prescription PO dilaudid and given this supposed safe supply for a period of time during the pandemic, who then went and sought to supplement that and overdosed? Has there been any data on that?
The BC CDC completed some preliminary evaluation of risk mitigation guidance, and they noted that less than 0.4% of people who had been prescribed risk mitigation guidance prescribing, which is the tablet dilaudid using BCCSU's guidelines, less than 0.4% of them had died. And those that did die had also been using fentanyl in addition to that. And so it's not tablet hydromorphone that's killing people in droves in BC and abroad. And there are other tablet hydromorphone programs outside of BC too, that have been happening in small pockets. That's not killing people. The illegal, volatile, and unpredictable supply is what's killing people. And so there's all of this trepidation about, well, what would happen if this person sells their tablets? What would happen if this person sells their pills? Well, that means somebody else isn't going to access fentanyl. That's a form of community harm reduction right there, right? But that doesn't equate to removing the liability experienced by prescribers as well. That's a public health way of looking at things. We know that sometimes people are going to sell their pills. We know that sometimes people are going to make an exchange. It's not always someone's capitalizing on your prescription. Sometimes it's situational. People have things in their lives and all of a sudden they need to make money or something like that. But the province completed an ethics analysis about this type of prescribing, and they actually hired a clinical ethicist to talk about all of these different various ethical dilemmas. And unequivocally, he came out saying there's still a moral obligation to do this type of work. Even if the person sells their pills, somebody else is going to end up not relying on the toxic drug supply. Even if you don't witness the person take it, you should still prescribe it. And it's because, contextually speaking, we're in a much different place than we were when people were blaming doctors for oxy prescribing. We're in a place now where overdose deaths are so high and continuing to increase at a rate that's like the sirens have been going by the window since I've started this recording with you. Yeah. And most of those are probably overdoses.
Yeah. So what do we, at this point, I know we see some positive things that are happening, and we see some trending in the right direction. As somebody who's been involved in this type of work and has been in the front lines for a while, can you tell us if you had a magic wand type of scenario where you had all the resources and authority to do whatever you wanted, what kind of a setup do you think would get us out of this jam the quickest?
Yeah, I mean, if I had a magic wand, there would be a lot of things different for sure. But listening to people who use drugs and people with lived and living experience of criminalization due to their drug use means that the most important thing is that we are uplifting what they're saying. And what they're saying is that they want to see full decriminalization of people who use drugs. They want to see expungement of criminal records for people who have been harmed by the war on drugs. They want to see legalization and regulation of substances so that things like compassion clubs have open doors to start operating, so that dispensaries could exist. And if we do that, plus some really important pieces like shoring up Canada's horrible mental health system,
yes,
and improving access to housing, affordable, safe housing for people, culturally safe housing, livable wage, food security.
Yeah, well,
it's not just drug use that's killing people, and it's not just these small things that are driving people towards drug use. We have some big cracks in our system in this country. And a safe supply of drugs is one small piece of a whole menu of options that we need full investment in and urgent investment in if we want to see some meaningful improvement.
Agreed. Yeah, that's a great answer. I mean, I hope we can. I don't know if we can solve all of those problems ever, but if we could even get a few of them under control, I mean, the main thing I think we are obligated to look at closely is the problem of the amount of just the people who are dying. That's what we've got to get under control first. We've got to get our supply stabilized somehow so that this isn't continuing to increase. The rest of the social issues and stuff like that, those are long-term things that may or may not work out, but they're all connected. I understand what you're saying. It's tough to parse it out, but so when you're doing this, I think you've done, as a healthcare professional, you're doing obviously stuff related to nursing itself, but you're also kind of an activist for safe supply. What kind of what has worked as far as getting changes to actually happen in a meaningful way, and what kind of hurdles or pushback have you faced as far as running into governments who just want to shut you down immediately?
Yeah, I mean, I think one of my top learnings is that you can engage, consult, and advocate until the end of time and try to win people over. You can employ all kinds of important strategies like the positive deviance approach and bring in your naysayers and co-opt them so that they become champions for a new initiative. But direct action has been the most effective. The government, for all intents and purposes, is not going to save us. They're not going to show up and suddenly be like, you're right, the war on drugs was wrong. We're going to defund the police. We're going to do this and that. We need to see direct action. And so some of the most effective ways that drug policy changes and innovations in the overdose crisis have emerged have been from primarily people with lived and living experience taking the risk to open something and to just do a thing in the absence of action of larger institutions and organizations. Stories of Insight's early days and how consumption sites first started, how needle distribution programs started up. None of that came out with the full carte blanche of the government. It came out with people taking a chance. Oftentimes people mobilizing the power and privilege that they have in order to make that change happen. And the same thing happened like with the way that our program started here in Victoria. when the risk mitigation guidance documents first were rolled out, it was myself and another nurse in a homeless encampment just calling all of the doctors we had in our contact list on the phone and asking which one of them would be willing to try and prescribe someone a safe supply, and then trying to develop a network of those doctors so that we can grow the practice a little bit. It was lucky that we received funding so that we could actually formalize the process, but it started early on with a cell phone and just lots of individual advocacy and the decision to do this now with or without funding, and to see what happens, because governments will also, they will sanction something and then they will take it away. And you only have to see, what happened to Crosstown Clinic. They had to go to the Supreme Court because the Harper government was trying to shut them down. Insight, the Harper government tried to shut them down, but they couldn't, because they started it anyways, and people were using it and people were benefiting from it and lives were being saved. And so then the government couldn't take it away. And so it's the most difficult thing because it means assuming risk, but it is likely the most effective means of advocacy that I've experienced.
Yeah, that it seems to check out as far as what I've seen as well. Just for our listeners and myself included, I'm assuming that by lived experience or lived in experience, you mean people who have used substances or been around environments where substances are being used. Is that what you are referring to?
Yeah, people with lived and living experience of criminalized drug use, of being criminalized for that drug use, of experiencing intersecting factors, including chronic mental health challenges, including poverty, homelessness. They understand the solutions best because those solutions are intended for them. And the mantra of nothing about us without us is a really important thing to park in the back of your head, because so often you will go into policy meetings, you will go into really important decision-making meetings about a certain population or about a certain community, and there is zero representation or inadequate representation from that community. And those are the programs that end up flopping. Those are the ones that nobody benefits from or nobody accesses it. And that's because it wasn't designed or led by the people who are most impacted by it. It's a concept that extends beyond substance use and the toxic drug supply, with people who have disabilities, that they need to be involved in designing and implementing programs that affect them. If we don't do that, then we're going to continuously cycle through failed interventions.
Yeah, they seem to cart out these type of approaches almost aggressively when they want something. They're trying to stop something from moving forward, or they're trying to stymie a process where they'll get many people involved who have the authority to make decisions regarding regulations, and very few of them have actual experience in the very problem that they're trying to regulate.
Absolutely. As a nurse, as a very privileged white settler in stolen lands working in drug policy reform, everything to do with my work has to be grounded in the feedback and experience of people who are actually impacted by this crisis and who are impacted by it daily. Otherwise, you will tokenize people, you will produce ineffective outputs, and ultimately cause more harm in the long run.
Interesting.
How do you prevent that from on a higher level, on a government level? Do we within the community of drug users, is there a feeling or is there a sentiment that this is just sort of tokenizing, that this is the government looking to improve the optics, or is there a good discourse? Is there good engagement?
I think that there are some really powerful and effective advocates from drug user organizations. There are some really effective organizations like the Canadian Association of People Who Use Drugs, like Vandu. There's all kinds of organizations out there, Western Aboriginal Harm Reduction Society, who are more and more involved in the process of policy change, of program development, but quite often governments still employ tokenizing tactics. Quite often they are looking to check a box. And as someone who has privilege and is involved in some of these conversations, if I'm looking around the table and there is not adequate representation, I need to full stop right there and tell them that that needs to change. And if it doesn't, then that's not something that I can be a part of. And people need to be prepared to vote with their feet. Because if you have privilege and you're working in the sector, you got to make space, and you have to find a way to uplift those voices who are most impacted by the issues you're discussing.
Yeah. Hell yeah. Great answer.
We see that me and Corey Williams have been talking about how politicized everything is right now, and how politicized even this issue of safe supply, consumption, all the way back to needle exchanges. It's too bad that has to be. And I wonder if we'll ever get to a point where we're able to look at these things pragmatically without, just from almost a rational viewpoint, where it's objective truths, what's actually helping people, what's not, and implementing programs that work towards that end without all the extra, attachments of your identity as a this or that politically. But what kind of stuff did you see in Alberta, like as far as contrast there with policymakers versus what you see in BC?
We had 4 years of an NDP government in Alberta where the keys to innovation were provided, and it was a relatively pain-free process of approaching the government and a collaborative opportunity to drive change forward. But it was incredibly short-lived, and what really became aware to me, at least working in Southern Alberta, was that for every single person that can listen to this podcast and nod their head and say, hell yeah, there's another 50% of the population that's saying, fuck this guy. And he's enabling, and that is deeply entrenched within subcultures within this country. We are taught that drugs are bad. The media will tell us that drugs are bad and people who use drugs are bad. The police, when I was in high school and middle school, came to our school for the DARE program, and they made jokes about people who use drugs. And then they held up an egg and said, this is your brain. And then they smashed it on the ground dramatically and said, this is your brain on drugs. And this is what people grow up believing. And until we can really get to the root causes of the drug war, which is racism and colonialism and all of these things that are embedded within a lot of systems in Canada, we're going to really continue to see a general pushback on this type of innovation, even if the evidence is there. If you look at what's happened with the pandemic, it's really highlights the fact that people aren't always interested in science. Right. And actually that science can be demonized and can be viewed as, just another leftist institution to oppress certain people or to push forward agendas. And all of that stuff is really ingrained in a lot of folks here in this country. And so it's not just going to be resolved through awareness campaigns, which you'll always see these different health authorities or governments put out ads about how fentanyl is bad and it will kill you. Everybody knows that there's fentanyl in the drug supply. Everybody knows that people are dying by a toxic drug supply. Awareness alone is not effective in preventing what's happening right now. If we want to see an end to these types of stereotypes and the stigma and the discrimination, we have to attack the law that's causing it. People feel empowered to discriminate against people who use drugs because of the illegal nature of that drug use. And if it wasn't made illegal, there would be more acceptance over time, much as there were with things like alcohol and cannabis.
Yeah.
Corey, I wanted to ask you about northern communities. That's something I still, a couple of years ago, particularly, after Trudeau was voted in, we were starting to hear that this was going to that we were going to build the bridge with the North. On this particular issue that we're talking about, I don't hear discussion there about harm reduction, about safe supply. You hear about the dire effects of alcohol prohibition in some communities, but are there gains being made? Are there things that are moving in the right direction in northern communities in this front?
Oh, define the right direction. Drug trends happen over time in Canada. And so while Vancouver's downtown east side was the epicenter of fentanyl poisoning and likely because it's also the site of the first criminalization of drug use in Canada, so those issues tend to come there. It's also a port city, and then larger urban areas are impacted by it, and you could actually see the trickle-down effect happen in smaller rural and remote communities across Canada. And just recently, the Yukon government has declared overdose as a public health emergency. So what we're seeing is that no community is left unscathed from it, but the means in which these drugs enter communities happen at different times and in different ways. Yeah. And so the fentanyl has arrived in most jurisdictions in Canada now, but it definitely took longer. Same with the East Coast and the Maritimes. It's there now. It wasn't there right when it was there in Vancouver. So it's unfortunate because now that it has been declared a public health emergency, there has been more discussion and conversation in the Yukon about a safe supply and about harm reduction. But up until then, it was quite quiet. And so once again, you see people being in a reactive state where they're waiting for this train that we can all see bearing down on us to get really, really fucking close. And then we're going to start trying to figure out how to get off the tracks.
Yeah. I just find it fascinating how back when this started in whatever it was, 2016, and it started to become news, how many people were dying of overdoses. And I thought at one point a couple of years ago, before the pandemic, that surely there must be a number. There's got to be maybe when 10,000 people die, maybe when 20, 25. And I've realized since then that there's never going to be a number that's going to change the way people feel about that situation if they have the idea in their head that those people are of less value or are disposable, and it doesn't matter because, it's not affecting me directly, that kind of an attitude. So, although, at this point, with the amount of people we've lost, you'd think that almost everybody in BC must have, either somebody close to them or removed once or twice, maybe at the most, who's either died or been harmed in some way by this. But looking into the future, if you can, what do you see happening as we kind of transition away from the COVID situation and we continue to struggle with this problem? What do you think? Where do you think we're trending, and where do you see us in 5 years?
In terms of the toxic drug supply, or in general?
Let's stick to this drug supply.
Good. I don't have that kind of crystal ball. I don't have any crystal ball. I do have history to lean on, and history has a tendency to repeat itself. And my biggest concern is that as COVID starts to fade, or we push it into the fade, because it's still happening, everyone, it's still happening. But as we choose to start to ignore it a bit more, that there will be some belief of return to normalcy and less of a desire to concentrate our efforts on other issues like housing and the toxic drug supply. I think people are pretty burnt out from bad news and are pretty numbed to death rates and more statistics that show how bleak things are. And there is still so much moralizing of drug use that there is apathy embedded within our politicians' decision-making process. My hope, so not my crystal ball, but my hope is that we can continue to drive change forward with a legal safe supply, with a regulated safe supply. My hope is that we do start to see demedicalized models where people can access compassion clubs, where people can go to regulated dispensaries, that drug checking services are more readily available to folks who need it. And truly, my hope is that we actually start to see in the next 5 years some movement towards decriminalization. And I believe that conversation has been happening more and more frequently. I believe that there has been acknowledgement at the federal level that change needs to happen. There's been provinces applying for exemption for decriminalization. There's been municipalities applying for decriminalization, micro decriminalization. It's all still fraught with issues and challenges, mainly the police being involved in most of those conversations. But they are incremental steps towards where we need to get to. There is harms in incrementalism as well, half measures.
Yes.
And there's the potential that something sloppy gets put together, people decide it doesn't work, the new government comes in, change in ideology, and we lose what we've gained. And so it needs to be consistently framed around people who use drugs and what they're telling us. We can't actually settle on half measures. We can't, let the government compromise with us. We have to keep going back to them and saying, this is what we're being told is needed, so this is what we need to do.
Yeah, I couldn't agree more with the half measures statement there, and I agree that it's almost employed as a political tactic to concede a little bit of ground so that whatever project you're working on to lend evidence to your cause fails, and it fails because of the half measures, not because it was a bad idea, but then that gives the media an opportunity to reinforce the old viewpoints that they were holding on to in the first place.
It's eerily reminiscent of what happened with Safe Supply in BC. Hyper medicalized model framed under a withdrawal management approach, not super accessible to people. How come people aren't liking this? Look, we tried.
Exactly.
Let's go back to what we were doing before and pretend this never happened. That's super harmful. Mm-hmm. And that's why we need to take that and keep blowing it out so that it does become something that can't be taken away.
Yes, agreed.
Well, back to the moral high ground stance that we so often see still here on a street level, still here at a dinner party, the stance that the quote, these people do it to them, or they're doing it to themselves. Corey, what do you? And I can't imagine that you run in a circle of people who would dare say that to you. But what do you say? How do we, as empathetic people who want to understand the issue, who are curious about the issue, who have loved drug users, who have seen our patients, etc., how do you respond to that, to these people are doing it to themselves adage?
Well, it's a logical fallacy, because people aren't saying that for folks who have lung cancer because of smoking cigarettes, their liver cancer because of their alcohol use, or diabetes related to lifestyle issues. Everyone is deserving of healthcare, and for some reason we are still so much more comfortable moralizing drug use. But we will not apply that framework to anybody else. And that speaks to the stigmatization that comes from criminalization of people who use drugs, because we're not telling folks that they only get one shot on the AED if they go down in a hockey rink. We're not telling people that they have to pay for all of their own chemo drugs. Like, why are we doing this for one group of people who are dying at an alarming rate? We're doing that because of stigma. And so, I do actually often run into people who say things like that. I've left my car in my driveway and had someone walk up to me and say, "Oh, you just give people free drugs?" as a way of starting a conversation point. And truthfully, I will engage sometimes, but more often than not, it's not my job to educate every single person who wants to walk into a conversation like that. It would be great if we could change every single heart and mind but we would be spending decades and maybe still not getting there, when we need to just be okay with the fact that some people are going to be awful to some people because they've chosen to, and because they haven't had a life experience that's changed them, because they haven't had the education that they need, because they haven't had the right thing, relate to them. And we need to just be able to sometimes walk away from them and continue doing the work that we're doing.
The article, there was the devastating article about you and about an incident where you were providing naloxone and you were heckled.
Yeah.
And I mean, so that's on the far end of the spectrum. You got to be a ice cold son of a bitch to be willing to heckle someone who is saving a life, and to be doing that in front of a person who's dying. But I mean, just for our listener, that's the extent that this can go.
Yeah, all I could think, that person yelled out, "Oh, just let them die." And all I could think was, could you imagine waking up from dying, being resuscitated, opening your eyes, and that's the first thing that you hear is some person who's never met you before, who doesn't know you, just completely being okay with you not being here anymore. And that is the reality that people who are victims of toxic drug policy here in Canada face every single day.
Yeah.
Is that there isn't just an apathy, but there is a disdain towards people who use drugs. And it isn't grounded in evidence or reality. It's grounded in stigmatizing and moralizing and othering.
Yeah. Yeah.
That's a great response. You've mowed through our questions and answered them superbly, as if they were nothing. I think you've practiced these speeches a couple times, maybe.
I am just really passionate about this, and I don't really have much of a life outside of this work. It's something that's important to me. It's something that people that I love and care about, I've lost. It's it's something that we need to talk about and need to be prepared to talk about. So I really appreciate the opportunity to be here and for all of your questions.
Can I ask you, Corey, how do you recharge? How do you self-care? How do you take off these hats at the end of the day?
Oh, well, I mean, I wish I was great at it. I would say that I'm learning, and that many of us are. And part of being able to navigate just wave after wave of loss and grief is to have a group of solidarity folks who you can talk to and debrief with, who do understand it. This is not stuff that I go home and talk to my young children about. This is not stuff that I, am prepared to share with people on a regular basis. But I do have a group of people who do similar work, who I can have a little bit of time to debrief, and then to make space for them to debrief as well. And that's a really important piece. And then other than that, my dog and cannabis, maybe.
Yeah. Dogs are a gift. We don't deserve them.
No. Yeah. My golden retriever probably needs a therapist for all of the things I've trauma dumped on him. I think that we can leave you there as far as our questions are concerned. If there's anything you wanted to get out there on this podcast, please feel free to take some time to do that, or anything that you want to plug. We're all ears. No, I mean, I think if folks are more interested in learning about safe supply, I'd encourage them to go to the source and look at resources from Canadian Association of People Who Use Drugs, to learn from people who use drugs in order to really give yourself a fulsome idea of what's being asked and why it's being asked. If you want to see more access to safe supply, write to your MLA, write to your MP, ask for demedicalized options for safe supply, ask for better options for housing, and make sure that, if you do encounter that person at the dinner table or the neighbor, know that you don't have to answer, but if you want to do a small thing, correct them the next time they say something stigmatizing about a person who uses drugs.
Yep. That's great, Corey. Thank you so much.
Yeah.
Thank you.
It makes me, it gives me some hope knowing that you're out there doing the type of work that you're doing. It's tremendously important, and I can see that you're passionate about it. So taking the time to talk to us today is, we're very grateful, and we wish you the best moving forward, and we'll be keeping our eye on you.
The gratitude is all mine. Thank you so much for having me.
Thanks, Corey, for cheering you on.